So this evening, for the first of the How to Be Good series, I'm talking to Dr. Rebecca Fitzgerald, an oncologist based in Cambridge, about medicine and about how goodness works there, halfway between an art and a science, she says.
Put at its plainest, I think, to be good as a doctor is to put the patient absolutely at the centre and to make the patient your prime concern. Now that perhaps seems obvious and perhaps seems very straightforward. But if we unpack that a little bit, I deliberately use the word patient and not disease. Because often as doctors what we focus on is the disease. And medicine has become very technology focused. We have a lot of data. So as you know, I'm a cancer doctor. And so we have more data available to us than ever before on a different level than we've had before. So we have data about the patient's symptoms, about their scans, about their pathology, but now even down to the level of molecular detail about the mutations in their tumour, say. And so this phrase has been coined, particularly in the context of cancer medicine, but actually more generally as well, about doing personalised medicine. And when I first heard that term, personalised medicine, that made me wince, actually, because I thought, what is medicine if it isn't personal? Surely what medicine is all about. I think of medicine in a way as a kind of the ultimate blend of science on the one hand and art on the other. And if it's not personal, then to me it's science and it's not medicine. And I think it's about having an acute diagnostic sense of what humanly matters, if I can put it like that. So let me perhaps make this a bit more of a real life sort of context, an example. So every Wednesday morning at 8 o'clock, we sit down as a team of specialists of esophageal and stomach cancer. And there are about 20 plus people in the room, including surgeons, radiologists, oncologists, the radiologists looking at the scans, nurses, people taking notes, the whole shebang. And we'll go through about 30 patients discussing mainly the data. And we formulate a plan for each patient. And then in the afternoon, I have my clinic. And so very often, some of those patients we've discussed in the morning, I will see in the afternoon. So at the point at which we've had the discussion, I've not met the patients. So when I get to my clinic, I have a sort of plan in my head that we've discussed. We've come to an agreed plan. I have it worked out. I perhaps have a mental image of the patient. You know, I know their age. I might know whether they are living on their own or not. You know, whether I'm going to be imparting very bad news, what we might be doing about it. But until the point that I meet the patient, they're a stranger to me. And everything changes once you invite that patient into your consulting room and enter into that conversation. A conversation which is going to get very intimate very quickly. Over a very short period of time, that's the other thing about medicine, you know, you have the liberty to ask people extraordinary personal questions to get really to the heart of what matters to them. And I saw a patient just a few weeks ago. I sort of thought I knew exactly what we were going to be doing. Called in her and her husband, and it very quickly became clear that their prime concern was to get to their son's wedding. That was what mattered to her. And my plan had to be turned upside down to accommodate what was most important to them at that time. And that seemed to be a good thing and the right thing to do. So I was trying to think, what is it that's being good? Is there another phrase for it? What's the essence of it? And I guess the nearest I could get to it in a way was the concept of loving kindness, which I don't think is a word that translates terribly well. But I was doing an interview for a new consultant in cancer medicine a little while ago now. And, interview process, we were going through all the usual things to assess competence, really, what would they be like as a colleague, how they'd work in the team and so on. And the lay chair of the panel leaned forward and fixed the interviewee in her gaze and said, "And so, Dr. Smith, are you kind?" And I'd never heard that asked in an interview before. But, it was absolutely to the point. And there was no escaping. At that moment, everyone's attention, the panel, I think, was slightly taken aback. There were about 6 of us. And clearly, this interviewee had not been expecting this question and had to really ponder. There was kind of nowhere to hide. It wasn't about, are you nice to your patients? And I can't remember what he said, except that I remember thinking that he answered it quite well and thinking, oh, how would I answer that question? So I think then to be good is something about how you bring together your scientific knowledge, your expertise, with your sort of experience that you've gathered, your insight, maybe wisdom, if we can use that word, to try and really get to what it is that humanly matters to that person at that time in their context, enter into their world a little bit so that you can come up with what hopefully is good medicine.
Let's go back to that word personalised. And I can see why you hesitated over it when you came across it. Because yes, medicine must be personal. It's certainly always personal from the patient's end of the experience. And yet the kind of intimacy you're describing between a doctor and a patient when it's going well, it kind of is personal and it isn't as well. I mean, there are ways in which you don't want your doctor to be your friend.
Right. No, that's a very important point. And I think that's especially hard when you start out, actually. And, often it's the most junior doctors that are with the patients the most on the ward, getting to know them very well. And it can be very hard to get that boundary right. Sometimes you're there with them at the lonely points in the middle of the night. They need someone to talk to. They will share things with you that they might not share with a senior colleague. I remember doing a lot of inpatient work with really young, very sick cancer patients. And, many of them died in our care on the ward. And I think it was when I'd been to the 3rd funeral that I realised, and my husband certainly realised, that this was not actually helpful, sustainable, and probably not helpful to the family, actually. I mean, somehow it does that was crossing the line, I think, between being a friend or something else. We haven't talked about science at all.
No, we haven't.
A lot of what I spend my time doing is research. So running a laboratory that's trying to find new diagnostic tests for cancer. And many consultant staff in teaching hospitals are actively engaged in research. And some of the metrics and rewards for research are very different than clinical medicine. So, and some of these things can sometimes cause tension, I think.
Can we be explicit
So,
here? Metrics and rewards, we mean that the professional payoffs for successful research
Yes.
are rather different from the professional payoffs of patient care.
Exactly. So in research, it's a very competitive business. So you're trying to be first, to discover something, and of course, if I'm doing research into cancer, I've got the patient's benefit in mind, but the rewards that me and my team are going to get to enable us to keep getting funding to do more will depend on publishing first in the best possible journal and raising money through grants, which might disincentivize us for doing some of the things which would benefit patients the fastest. What I mean by that is, so when I've got this new body of data, do I share it openly with other scientific colleagues so that they can then immediately have access to that data to improve their knowledge and their advance? Or do I keep it, at least to start with, to ourselves so that we can profit, if you will, from the science that we've learned to enable us to do the next bit and to promote the careers of me and my staff? And their careers will depend on, getting the next grant and getting that paper for their promotions. So this can be a real tension.
So that's a moment when there is actually a pull in different directions between at least the short-term interests of patients and the short-term incentives of a medical career. How does it tend to get resolved? I'm not asking.
Well, I think this is where I do see this all the time. Different lab heads will have a very different view on this. Or they'll behave differently anyway, even if they don't necessarily want to articulate it in that way. But there are, some people who really are very jealous of the data. And
belongs to them.
It belongs to them, and really they're self-interested, and they're clearly wanting to, to win the race, to score the points, to get the best paper and so on. And that really is all that matters to them. And at some point, I guess they'll, and by the way, when you publish a lot of this stuff now, you have to release the data at that point. So it's not as if they won't ever share the data, but they'll do it on their terms to make sure that they maximise the success for them and their team. And other people who I see that are much more willing to share. And I think if you're willing to share that, I wouldn't want to say that's the exception rather than the rule, but I think it does, those people stand out a bit at the moment as being perhaps a bit more bold to really put those principles at the forefront and say that, the most important thing is to share this data. And actually there's so much data here, especially with a lot of the sort of work I'm involved with DNA sequencing. I mean, there's so much data that, it would be ludicrous really to think that you had to keep it all to yourself. But I think the research community has still got a long way to go to really work together more and get rid of some of the competition and the barriers.
Would it sometimes be easier not to have faith in decisions that you have to make?
I think for the patients, interactions, it helps me certainly, we're all fallible and it goes wrong, and being able at the end of the day to say, I come to your table trusting not in my own righteousness but in your manifold and great mercies, that's helpful. The place I find it most difficult is what we've just been discussing in the science, when I think, you know, my conscience is pulling me one way, and the kind of competitive field that I'm working and trying to keep my head above water in sometimes makes me think that I might be erring on making decisions which I don't feel so happy with. And actually when you were, I've occasionally had moments thinking, gosh, if I look back at myself, you were saying, you know, what would surprise you about when you were a young doctor to when you are now. And I think now some of the things I do in the lab and the decisions we make, there's that real tension, and you know, you have to be competitive to some degree, and I find that a continual battle, and I wonder if it's more of a battle because of my faith perspective. I don't know, perhaps that just makes my conscience more, but maybe not, I don't know.
Would you want to be without the difficulties of your conscience then?
No, I suppose. I'm glad that it's there to keep me, you know, pulling me in. It does, it's there for a reason, isn't it?
Thank you very much, Rebecca Fitzgerald. Well, next time, in the second of the How to Be Good series, I'll be talking to the novelist Sarah Perry, author of The Essex Serpent, about how you set about being good if your job is making things up. To avoid missing any of the series, subscribe on the Ely Cathedral YouTube channel and press the notification bell.